look at it really quick. Alright, as you look at V2, you see it kind of starts off with, like, can't really see any, like, distinguish between, like, the P wave and the T waves. Kind of looks like there's, like, multiple P waves, maybe multiple T waves, and it's definitely starts off as, like, a tachyrhythm, and then you could see, like, after the 1-2 second QRS, you see the gap, and then it gets back to kind of quote-unquote regular before it gets irregular again. And those QSs are definitely not normal, a little wide. And then when you go to, like, V1, V2, even, like, V3, and you look through there, it's, super abnormal, you can tell. And just by looking at that, if I was to take, like, a whack at trying to determine what it is, I'd say it's an idioventricular rhythm. And since it's fast, a faster rhythm, I'd probably say, I don't know, accelerated idio, or maybe a ventricular tachycardia.
All right. So you identified a lot of abnormalities, and you're on track for identifying things that look out of place. The problem is you're not taking a systematic approach to identify the simple things that help describe particular rhythms, right? So let me point out some things that you identified, but you didn't correlate to anything.
Okay.
So if I go to lead 2, right, which is my primary lead for interpretation of the underlying rhythm, do I see any discernible P waves? Is there any P waves that jump out at me?
No.
No, right? So, okay. So I've got no discernible P waves, and when I don't have any discernible P waves, what's the number one rhythm that jumps into my head?
I would say an idioventricular rhythm. There's no.
Okay, so it can be IVR, and you're heavily influenced right now because you keep getting sucked into this wide QRS, which is okay. But what's another really common dysrhythmia that does not have a discernible P wave? They both fall under your SVT umbrella.
Yeah, I would say ventricular tachycardia.
So we've got VTach, we've got AVNRT, right? A junctional tachycardia. We've got atrial fibrillation, right?
Yeah. VFib doesn't have P waves, but I don't think this.
But we've got clear and evident QRS complexes, so VFib's definitely out.
Correct.
All right, so far I've got no discernible P waves. I'm thinking my number one, dysrhythmia for no discernible P waves is going to be atrial fibrillation. So I'm going to kind of keep that in the back of my mind here. Okay. By QRS, it looks wide. It's I didn't count it out, but to the natural eye, it looks wide to me. And if we count it out, it's greater than 0.12. So I've confirmed it's a wide QRS. So far, I've got no discernible P wave in a wide QRS. My number one threat right now is VTach, okay?
Yep.
And now I start to go to my R to R interval because it's really hard to see my T waves here. And one thing that pops out my R to R interval is what? Does it look regular?
No.
No. So now I know there's a 99% chance that it's not VTach because VTach is 99% to be a regular rhythm. The foci in VTach, although it can be polymorphic, right, it doesn't tend to produce irregular depolarization of the ventricles. 99% of the time it's going to be a regular dysrhythmia. So my suspicion of VTach is super, 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 super low now, almost to the point where I'm not even going to consider VTach. So I've got no discernible P wave, a wide QRS, and it's irregular, right? So then when I kind of pay closer attention and I keep running this strip, I notice that it's irregularly irregular, meaning there's no rhyme or rhythm to the R to R duration. So now I've got no discernible P wave and an irregular R to R ratio. What rhythm do I have? It's irregularly irregular. What is the only dysrhythmia that's irregularly irregular that has a QRS complex? There's only one.
Regular, irregular, discernible QRS. Honestly, I'm drawing a blank right now.
Atrial fibrillation, right? So the atrium is quivering. So here's my fibrillation line.
Yeah.
And every so often, it's flying that impulse through that ventricle, right? Then AV node is doing the best it can to limit that 300-400 beats per minute of the atrium, and it's preventing as well as it can to prevent those depolarizations, all those impulses moving to the ventricle. But because it's so irregular, it's fibrillating from the atrium, it's producing this irregular rate at which that depolarization penetrates through that AV node and gets down to that ventricle, which is what's producing that irregular R to R, right? And atrial fibrillation is never going to have a pattern to their R to R interval. It's very sporadic. It's irregularly irregular. So now I've got no discernible P wave, wide QRS, an irregular E to irregular R wave. So I've got atrial fibrillation, and because I've got a wide QRS, I've got an aberrancy here as well, right? I've got an aberrant conduction. So where should I go to identify what type of aberrant conduction I have? Go up to my V1, right? Look at my septum. My septum, V1 is looking right down the center of that heart, right? Right in the septal wall of that heart. So it's a great way to identify where that aberrancy is taking place through that bundle branch, okay, or through the fascicles, okay, because it's looking straight at that myocardium, right at that septal wall, right where that right and left bundle branch bifurcate out past that AV node. So I'm looking at V1. I've once again confirmed I've got a wide QRS here, and by looking at this QRS complex, do I have a Q wave? Here's my isoelectric line, and the first thing it does is drop straight down, right? So I could have a Q wave, but remember, a Q wave is only going to come before an R wave, so I'd have a positive spike here. Do I have a positive spike? No. Most importantly, I see this big negative spike, and my QRS ends because it goes right into my T wave, right? So I have what's called a terminal S wave, yes?
Correct.
And when I've got a wide QRS and a terminal S wave, what type of aberrancy do I have?
Wide QRS.
Left.
I've got a left bundle branch block, right?
Yep.
Slap the blinker down, right? Turn left. Pop the blinker up to turn right. Pop the blinker up, that's your terminal R wave. Slap the blinker down, that's your terminal S wave. So I've got atrial fibrillation with a left bundle branch block. That left bundle branch block, that's what kept sucking you into this VTAC, because the morphology of a left bundle branch block is very similar to a ventricular beat, right? A beat that originates from the ventricles, because it produces that wide, ugly terminal S wave with that wide, large T wave. That's your natural morphology for your left bundle branch block. And it doesn't help that it's pretty fast, right? Let's look at the rhythm. Let's look at the rate here. I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 140, 150 beats per minute. So this looking down here, this looks just like VTAC, but then when I see that irregular R to R, I know instantaneously, man, it's not VTAC. This is definitely going to be it's irregularly irregular. It's atrial fibrillation. I've got no discernible P waves, right? That confirms AFib, and then on top of that, I've got a wide QRS, which I now know is a left bundle. So quite frankly, I've got atrial fibrillation with an aberrancy in the left bundle branch block. But that rate, 140, 150, could this be treated? Yeah, absolutely, right? This is definitely an individual that may be complaining of palpitations, chest pain, shortness of breath, right? Atrial fibrillation with RVR. And we know that because it's in regular LEGO, we're going to see that ventricular rate shooting all over the place, 140, 160, 180, 120, 130. And because they're symptomatic, we want to consider an antidysrhythmic in the position of a calcium channel blocker, right? So your cardizem, your verapamil, you can even consider your amiodarone. To help to inhibit the uptake of that calcium, to slow down that depolarization, right? To maintain that slow down the repolarization, to maintain that depolarized state. So if I want to consider cardizem, how would I dose it? How much would I give?
0.25 milligram per kilogram.
Yep. And what do I know cardizem will do when I administer it? It's going to do a couple things, right? It can slow down the ventricular depolarization because it's prolonging the depolarized state, right, which is inhibiting repolarization. But it's also going to affect the cardiac inotropy, the squeeze, right? So it's very common for us to see hypotension with the administration of a loading dose of cardizem, like 0.25 milligrams per kilogram. Cardizem can either A, just slow down that ventricular rate, but the patient remains in atrial fibrillation, or that loading dose can actually convert them back into a sinus-based rhythm. And I would much rather slow down, especially if they live in AFib, slow down that AFib, prevent that conversion to a sinus rhythm, because now if I convert them and they live in atrial fibrillation, what are they at risk for?
You're saying if you correct the rhythm, if they live in AFib and you correct the rhythm?
Correct, yep. And if I convert them back to a sinus rhythm. Thinking about my atrium is quibbling, right? It's fibrillating. So some blood is doing what? It's pooling, it's coagulating, right? What are most AFib patients on?
What is it? Is it digoxin? How do you say it?
That could be to control their rate, but they're generally on a blood thinner, right? An antiplatelet or a blood thinner, whether it's Coumadin, warfarin, Eliquis, because that fibrillation and that blood's going to pool down at the bottom of the chamber, and they want to minimize the coagulation there, so they put them on a blood thinner. When you convert them to a sinus rhythm, now you've got that atrium that's beating normal, and a little bit of that it's kind of like the gas on the bottom of your tank, right? It kind of junks up. Same thing happens in AFib. So when you convert them to a sinus rhythm, you're going to move that junk from that chamber into the ventricles, and it's going to pump it out to the rest of the body. So